Good evening, everybody. We'll wait till everybody joins this evening. Lovely to have you here with us tonight. Welcome to the Improving Childhood Asthma Management Community of Practice When Spring Strikes. So this evening, for those of you who have been with us for the last few years, you will know, and for those new to us, is all things asthmas, allergies, and thunderstorms. We have the unique privilege in Melbourne to suffer from thunderstorm asthma, so that topic will be covered, and we'll have some information about allergies and desensitization, and then some things around the new asthma handbook guidance. And hopefully that's almost everybody joined. We'll get started. A lot to squeeze in today, so we're going to start promptly. We always start with an acknowledgement of country. In the spirit of reconciliation, we acknowledge the traditional custodians of the lands on which we meet, the Wurundjeri people of the Kulin Nation. We pay our respects to the elders past, present, and extend that respect to all Aboriginal and Torres Strait Islander peoples today, for they are the safekeepers of memories, traditions, and culture. We recognise their connection to country, land, and sea and community, and their role in caring for and maintaining country over thousands of years. May their strength and wisdom be with us today. Just a little bit of housekeeping. If you can keep muted until you're speaking, or unless you have raised your hands when we're in question time. You can ask questions via the chat box. I'll be monitoring the chat and bringing questions in as they arise, or keeping to the end of the presenters' slides. The session is being recorded, and you will be provided with a recording via email after the event. And please ensure that you join the session using the name you registered with, so we can mark your attendance, and for those gaining CPD points, so we can give you your CPD points. Just to change your name, if you click on participants, and if you are using the app, you can click on your name. If you're using the computer, hover over your name and click the three dots. And if you're using a Mac, just hover over your name and click more, and then rename to whatever you use to join the session with. By the end of this session, we hope you'll be able to implement best practice management for asthma in children, describe resources and local services available for children living with asthma, and identify collaborative, multidisciplinary opportunities to improve the care for children living with asthma. Also, there'll be an opportunity to interpret some of the local data and identify potential solutions to improve asthma care locally. Our facilitators this evening are myself, Kirsty Thomas. If you don't know me, I'm a GP with specialist interest in asthma, working in the outer western suburbs of Melbourne, and Dr. Catherine Chen, who is a general paediatrician at the Royal Children's Hospital. She will also be one of our presenters tonight. Our guest speakers, we have Debbie Rigby here. She's an advanced practice pharmacist and asthma educator, and is the clinical executive lead at the National Asthma Council Australia. She's a member of the Lung Foundation Australia, COPD Advisory Committee and Primary Care Committee, Thoracic Society of Australia and New Zealand, Primary Care Respiratory Society UK, and the International Primary Care Respiratory Group. We are very lucky to have our expertise here today. The Lung Foundation of Australia honoured Debbie as the 2023 Lung Health Legend. Danny Storis is a public health physician working in environmental health at the Victorian Department of Health, where he's been deeply involved in thunderstorm asthma, and we're very grateful for our expertise here again this evening. Dr. Bella Shadur is a paediatric allergist and immunologist practicing both at the Royal Children's Hospital and Max Medical Group. She has a PhD focusing on targeted therapy and bone marrow transplantation for rare inborn errors of immunity, and splits her practice between the care of patients with immune deficiency and those with allergic disease. She is passionate about research and harnessing research to inform best practice. Welcome, Bella, and thank you so much for joining us. If I could just get you all to introduce yourself in the chat so we know who's here. It's great to know the demographic of expertise we have in the room this evening. Just pop your name, your organisation and the role while we get started. So this evening, I have undertaken the welcome and introductions, and I'll be hosting. We have allergic rhinitis presented by Dr. Bella, then thunderstorm asthma presented by Danny, and then the new changes to the Australian Asthma Handbook by Debbie Rigby. And then Catherine's going to come and tell us some interesting developing research and evidence base, which is sort of new medicine from a recent Lancet paper. I'll wrap up the evening and then we will say goodnight around 8 o'clock. So if I can introduce and let Dr. Bellashandur take over.
Thank you. So firstly, thank you for the introduction and thank you for inviting me to speak tonight. It's my first time speaking in this forum, so I hope I have pitched my slides appropriately. I do have to apologize that I may have to duck off after my talk because I have a toddler with gastro who is currently being looked after by my parents, and I also apologize if she tries to get in here. I could hear her a few minutes ago knocking on the door going, "Mama, mama," and my mum took her away. So just apologies if any of that interrupts things. Great, so maybe we'll move to the next slide. So tonight, I thought I was asked to speak about allergic rhinitis, so I'll talk briefly about what that is, and also the role of allergy testing, and then a few different treatment options, touching on conventional treatment options, and then also speaking a bit about actual allergen immunotherapy and desensitization. And yeah. So allergic rhinitis, as I usually explain to families, so rhinitis, I think about the nose, itis means inflammation, so inflammation of the nasal mucosa caused by exposure to allergens. And it's really important to distinguish that from nasal congestion caused by physical obstruction, so like polyps or a deviated nasal septum or anything else, or recurrent infections. And the reason I bring that up is because we often see like quite young children, you know, less than 3, less than 2, where parents are concerned that their child has a lot of nasal congestion and could it be an allergy? And in that really young age group, that's actually quite rare. And the classic is just trying to explain to parents that their child's probably just getting recurrent viral infections from childcare. But this, you know, often those children come to us having had a blood test for you know, house dust mite allergy or something like that. So I just wanted to make clear that, you know, there are different reasons for nasal congestion, and people are often quick to blame allergies, but in very young children, that's quite rare. And generally speaking, we sort of see 3 different patterns of allergic rhinitis. So the first one is perennial allergic rhinitis, so year-round symptoms. With very classic sort of nocturnal symptoms like a blocked nose when people try to sleep at night, you know, interrupted sleep, often being tired during the day and waking quite congested. And that's generally caused by house dust mite and its droppings, because there's a lot of house dust mite in our bedding. The other pattern that we see is seasonal allergic rhinitis, so that's classically hay fever, mainly caused by temperate grasses in this part of Australia, with peak symptoms being between October to December. So, you know, runny nose, sneezing, nasal congestion, itchy eyes, those really classic hay fever symptoms. But then we can also see people who have constant allergic rhinitis throughout the year, and which then gets worse in spring and summer. And so those people have a combination of both dust and pollen allergies. Next slide. So in terms of allergy testing, it's probably much of a muchness whether we as allergists do skin prick testing or whether people will have allergy blood tests. So previously we used to do RAS testing, now we sort of refer to it as serum specific IgE. And sometimes, you know, if the pattern that we see on the skin prick test result isn't what we expect, then sometimes we will double check it on blood tests and vice versa. So it can be useful to have both sets of information. But really the most important diagnostic tool is the history. You know, sometimes sitting in allergy clinic, you know, with, let's say it's a younger child, 5, 6, 7 years old, who's not very excited about having skin prick testing, and it's like a really obvious history of hay fever. A little bit, sometimes I think, oh, do I really need to put the child through this? Because history really is the most important thing. And like with any allergy test, people often put a put a lot of sway by allergy testing. People really treat it as though it's got some sort of halo. And allergy testing is very useful, but like with food allergy, the history is the most important. And a positive allergy test result, whether it's a skin prick test result or a blood test result, doesn't always mean you actually have that allergy. So I don't want to like burst the bubble of my own specialty, but sometimes, you know, people see positive allergy results and they think, oh, that's definitely the answer. But if the clinical history doesn't fit, then you know that's more important. And secondly, or furthermore, the size of the test result doesn't correlate with symptom severity, particularly for something like allergic rhinitis. You know, I've seen children who have a serum-specific IgE to house dust mite of, let's say, like 100, right? So very, very high. But they're like, oh, I don't know, I'm a bit snuffly sometimes, but I'm not too bothered by it. Whereas others have a much lower result and are just really irritated by it and aren't sleeping well and it's bothering them and everyone else in their family. And I think part of that is just because the tolerance for nasal congestion differs amongst people. But yeah, so I guess I wanted to make the point that just because there's a positive allergy test doesn't mean that that is necessarily the answer. Sorry, my room's gotten really dark for some reason. Yeah, so next slide. So in terms of, so the first thing we would do as allergists when we meet a patient who has allergic rhinitis, so go through the clinical history, do some allergy testing, and then I always make a real point of making sure that they are actually trying to minimize their exposure to that allergen. Now, you can't completely avoid things like house dust mite and pollens, but you can minimize exposure. So some of the most important things when it comes to house dust mite are washing bed sheets in hot water at least 60 degrees because house dust mite doesn't like high temperatures. And that will kill a lot of the house dust mite. And also changing the bedding weekly. There is also some house dust mite protectant bedding that you can buy. One particular company is an Australian company called Allergens. I don't tell people to rush to buy those bed sheets because they're quite pricey. But I usually mention them because families have inevitably gone to like a bedding store and everything in the bedding store seems to be hypoallergenic, often from a very dubious on a very dubious basis. So I always tell them if you're going to buy anything, you know, try this brand, but in general, try simple things first before you go spending heaps of money. So washing the bed sheets in hot water and changing them weekly can be really beneficial, particularly for milder cases of house dust mite allergy. I also make a point of vacuuming regularly, so once or twice a week, particularly if there are carpets. I don't tend to tell people that they have to get rid of carpets because that's not always feasible, but just making sure that they're at least vacuuming regularly. And also for younger children who still sleep with fluffy toys, they can often get really dusty. So trying to put them through the wash or at least a dryer on a hot temperature can be really helpful. Although sometimes young kids don't like that because they like their toys to be a bit stinky. But if they can, that can be useful. And also making sure that people are cleaning out their heating and air conditioning vents because those can accumulate a lot of dust. And then when it comes to pollen, I generally recommend that people monitor the pollen count, either by checking the newspaper or going on the Melbourne Pollen website or downloading their free app, which is really useful and sort of divides. I don't know why it's called the Melbourne Pollen app because it's a Victorian-wide app, but it will sort of highlight what the pollen count is in different regions in Victoria, and that can be really useful for families. If it's a particularly high pollen day and you know it's like a weekend and the child doesn't have to go to school and you don't have any big plans, and sometimes staying inside, particularly in the first half of the day, which is when most pollens are out, can be useful, but again, not always practical. But if you are inside, closing windows, closing doors, using the recycled air option in the car and having car windows closed, there's those sorts of simple measures to try and decrease exposure. And also being aware of the risk of thunderstorm asthma. which affects people who have a ryegrass allergy. Now, I know that the next talk is going to be focusing on thunderstorm asthma, so I won't go into that heaps. How, yeah, I'll just go back to the previous slide. I'm mainly focusing on the house dust mite and the pollens because those are the main things that we see cause significant symptoms. Often families will ask questions about things like mold and animal danders and that sort of thing. I don't allergy testing to mold is often not that reliable, and I generally recommend that if there's visible mold, that just needs to be cleaned away, and that's usually the best treatment for that. When it comes to animals, it can be a little bit tricky. Usually, if there are really severe symptoms, then you have to think about rehoming the animal because animal dander can hang around for a really long time. And you know, it's not practical to keep animals like always outside or in one room of the house. Their dander inevitably gets everywhere anyway. But those are less common, and it's generally house dust mite and pollens that cause most symptoms. Yeah, so next slide. So once we've got all our allergen minimization strategies going, then the next thing to talk about is actual symptom management, because like I said, you can't completely avoid those common allergens. So firstly, we recommend high dose antihistamines. So often families are just taking like one a day, or they're worried about taking too many antihistamines. And actually, we recommend taking or whatever the child's appropriate like once a day dose is, taking up to double that dose twice a day. So essentially 4 times the recommended dose. So for example, if it was a 5-year-old, they could have up to 10 milligrams of Zyrtec twice daily. So in the morning and in the evening. Families often ask us about cycling through different antihistamines. Some people feel that makes a difference. Others get good relief just being on the same one for years. So I think it's really individual, and families get lots of different advice about it. I tell them if you feel like the one you're taking isn't working as well, then try another one. You know, I think I'm not too strict about which one they use, particularly for the younger kids. It might come down to which flavor they tolerate more. So, yeah. Then, so making sure that they're really using the antihistamines as much as they can and as much as they need to. Then using the intranasal steroids. So my initial go-to is Nasonex just because it's the cheapest and it's been available over the counter without a script for a long time now. But sometimes I will also recommend Dymista. So Dymista, you may already know this, so stop me if you do, but has fluticasone as its steroid component, but also has an antihistamine included. I probably get 50-50 feedback from families about whether that addition of the antihistamine really makes a big difference as compared to just using straight Nasonex or Avamys. Avamys is also a great nasal steroid. It's just you need a script for it, and it's still about $45 a bottle. So whereas Nasonex is about 20 odd, and Dymista is about 30. So I tend to go with Nasonex or Dymista just for practical reasons. The other practical aspect of Dymista is it tastes foul. I don't know if any of you have tried it. It's quite bitter when it drips down the back of your throat. So a lot of kids really hate it, which obviously affects compliance. But yeah, generally maximizing one of those and really emphasizing to families that they need to use them for a good 6 weeks for them to daily to reach their peak effect. And making sure that they're using them correctly in terms of their technique. So blowing their nose really well, angling the head down and angling the nozzle out to the corner of the eye. So trying to stay away from the nasal septum. That can often be quite helpful. And I often need to make a point to the families because they're invariably saying, oh yeah, we use them like on and off and they don't really do much. And so sorry, I was just reading the comments. So yeah, and just explaining to them that it's quite different to the decongestant nasal sprays that you use as needed, whereas the steroid nasal sprays need to be used consistently. And actually, the National Allergy Council at the moment are doing a study where they're trying to recruit people to look into, that sort of poor technique that people often have with the nasal steroids. Sometimes for the older children, so more teenagers, I might recommend just a sinus washout. I don't think any of them actually do it because it's super uncomfortable, but it can help just clear a lot of gunk out of the nose. And I know the ear, nose, and throat surgeons like it, but yeah, I don't have great faith that many of them actually do it. And then also just washing the eyes out if they're uncomfortable. And I haven't included a picture, but also using either mast cell, like ocular mast cell stabilizers, or ocular antihistamine. So there's Zyrtec eye drops, or ketotifen or Zatidin eye drops can also be quite useful for those eye symptoms. So next slide. And then once families or once patients have really maxed out those options, that's when I would bring up allergen immunotherapy. So there are quite a lot of options on the market. Part of the reason why I really try to emphasize doing all your standard things first is because immunotherapy is expensive, depending on the product and the number of allergens. We're looking at between $650 to $1,500 per year. There's no Medicare or PBS cover for that. So it is an out-of-pocket cost. I think some private health insurance will give something back, but I don't think it's a lot. And it's a 3 to 5 year commitment. In most cases, 3 years, but sometimes out to 5. So it is a long-term and expensive therapy. So you want to make sure that you've really kind of earned it, for want of a better expression, and that it's really necessary. Whichever form of immunotherapy we do, the first doses are always given in our allergy clinic because there is a chance of having anaphylaxis or just even a milder allergic reaction. And there's a lot of debate amongst allergists about whether we use native allergen or allergoids where the allergen has sort of been manipulated. The allergoids are generally better tolerated and we don't really see anaphylaxis with those. But there is a feeling that perhaps they are not as effective or don't give the really long-term benefit that we'd like to see. But there actually, unfortunately, isn't a head-to-head comparison, so we don't really have hard data on that. And then also considering whether we just do a single allergen or whether we do allergen mixes. So yeah, next slide. And so these are just some of the options. So you can see that that's the order form on the left there for Clustek Max, which does good allergen mixes. So if you want to mix house dust mite and let's say one of the grass mixes, and again, there's debate amongst allergists about whether we do like one of the Australian grass mixes or 6 grass mix. There's a general feel that so long as you're targeting ryegrass, which is the main driver for allergic rhinitis, that there's enough cross-reactivity between ryegrass and other temperate grasses that you'll probably still have a good effect. But yeah, there's different allergists prefer different mixes. I've just included a picture of oral air there, which is a sublingual immunotherapy. So that is also available. And then Alustal, which is in the bottom right of that picture, has recently come back onto the market, sort of halfway through this year. So I guess one of the advantages, the Clustek Max is an allergoid, whereas the oral air and the Alustal are native allergen mixes. So particularly Alustal has higher rates of anaphylaxis, so that one we grade up the dosing much more slowly. Clustek Max needs to be, it's ordered from Europe and can take 6 to 8 weeks to arrive, whereas Alustal has local stock in Australia. So there's sort of pros and cons to each one, and it probably depends. So next slide, I'm going to go into that a little bit more. Yeah, so the sublingual immunotherapy, so there are three different options. So oral air is a 5-grass mix, and then the other two, Actair and Acazarax, are house dust mite products. So that's a tablet that you take under the tongue daily at home. So it dissolves under the tongue. You don't need to actually swallow it. It dissolves over about 30 seconds or something like that. Whereas the subcutaneous immunotherapy, so generally given in the upper arm, is done monthly at the GP. And there's quite a few different companies that make subcutaneous immunotherapy. That list isn't exhaustive. And different allergists prefer different products. And again, no great head-to-head comparison of them. So sometimes a bit of an evidence-free zone. And I think it's important to tailor the patient to the product. So, for example, if you had a teenager who's not really great at remembering to do their daily, asthma therapy or their nasal sprays, then maybe a daily tablet at home isn't the right option, and it's better to just have a booked in appointment at the GP once a month that they can't forget, and they just get that done. But in younger children who are needle phobic, then sometimes sublingual immunotherapy might be a better option. A lot of patients really dislike the oral symptoms of the sublingual immunotherapy. It can lead to quite a lot of like mouth tingling. Some get lip swelling, so oral discomfort, and that generally subsides with time, but some patients really don't tolerate it. I've spoken about the anaphylaxis risk with the native allergens. And particularly with those, it's important that patients have really good asthma control because there is that risk of anaphylaxis. So we make sure that we optimize asthma treatment first. We'll often get children to have lung function tests just to make sure things are that there's no ongoing reversibility in their airways, and we will give the product over more doses. So instead of like a 2 or 3 week schedule, we will stretch that out if they have asthma as well, just to be on the safe side. Next slide. And so yeah, I've just included a couple of good resources. I particularly like this handout from ASCIA, the allergen minimization handout, because it goes through minimizing exposure to house dust mites, animal danders, pollens, because it's a lot of information for patients to take on. So it's good to give them that so they can have a read through it themselves. And the ASCIA website generally, so the Australasian Society for Clinical Immunology and Allergy, is a really good resource. And I think that was my last proper slide. So yeah, happy to take any questions.
Fantastic. Thank you so much, Bella, for presenting a really interesting piece of information there about allergic rhinitis and allergy desensitization. Just looking at the chat, feel free to pop questions up there. Sometimes it takes a little time for people to warm up, so I'm going to start with a question of my own. As I understand it, the desensitization treatment is still made overseas. Do you still see much supply chain disruption? I had two adults try it a few years ago, and both of them got disrupted about 9 months and sort of failed to restart. And I've just had a child start it with Max. Is it still an issue?
Yeah, so last year we had really big problems with the Immunotech products. There was a change. I'm not exactly sure what the story was, but I think there was a change in the company ownership, and they basically, yeah, it was quite sudden, and then they weren't able to get product out to people. They do, Immunotech in their offices in Australia do have some local stock, but the issue with Immunotech, so you can't get it on a script. It's like a named medical product, so it comes from Europe specifically for that patient. So they were having to do some slightly dodgy things, like with their stock in Australia, like scratch off the original patient's name and then write someone else's on it. And it was making us all a little bit uncomfortable. And it was just really, they didn't communicate very well with patients or with us. And it was really, really frustrating. I think those issues have resolved, but there is always a lag time in getting the product. So it's about 6 to 8 weeks. So sometimes, you want to start the immunotherapy sort of traditionally we've wanted to start it a few months before pollen season hits, so you get a bit of a run in, and that with the supply chain issues that really knocked that plan about. And just because it can take so long to arrive, we always tell people that once you open one vial, order your next one so that there's no delay. Since Alustal came back onto the market mid 2025, they have local stock and they've gone through the process of getting TGA approval. So they are actually patients, we can actually give them a script. So I think they're distributing it through either Chemist Warehouse, but they can also send it out to families directly. And I think also the Royal Melbourne Pharmacy has stock. So that's been a lot easier. The issue with the Alustal products, so they also about a decade ago we were using Alustal and then they suddenly pulled their products without
Yeah.
any explanation. So a lot of many allergists are very scarred by that experience and don't want to use Alustal out of principle. I think others of us are more forgiving given the issues with Immunotech last year. But the main issue with Alicel at the moment is we think there's a significantly higher rate of anaphylaxis. And so we're still just seeing how the rollout of that is going and trying to
Yeah.
gather our own data.
Uh-huh.
There's a few different
Yeah.
things. Yeah,
I
it
think
has
it's just
been an
something,
issue.
yeah, it's important for patients obviously to know. Catherine has her hand up.
Yeah.
Thanks, Bella. Thanks, Kirsty. I've got actually two questions. The first question is whether your approach would differ if a patient also has asthma, particularly poorly controlled asthma. Would that approach be different? And the second question is around when do we refer to an allergist for allergic rhinitis?
Um, yes, if they have asthma, it would differ. I think it's really important in patients with asthma, if they do also have allergic rhinitis, to optimize their allergic rhinitis management, particularly just initially with those conventional measures like the nasal sprays and antihistamines, which families, patients are invariably at their first appointment not using appropriately. So I think that's really important. And just making sure that if they need to be on a preventer, that they're taking that properly and everything. So we would often spend a few months trying to make sure that we establish really good asthma control before starting immunotherapy. And when should you refer to an allergist? So I guess it depends where you want to see an allergist, or where families can see an allergist. So at the Royal Children's Hospital, if we get a referral for a patient that hasn't had any allergy testing and isn't on a nasal spray yet, we reject those referrals, but send back a letter saying, please do this, this, and this, use your antihistamines, high dose, please get some blood tests done, all of those sorts of things, and then refer back if that still hasn't helped, and also make clear to the patient the cost of the immunotherapy. So I think if the patients are wanting to go through the public clinic, I would get all of those things done first. So it's a very clear request for immunotherapy. That's sort of, I think through the Royal Children's, we kind of want to see the pinnacle of or the tip of the iceberg of patients with allergic rhinitis. I think if you're going through a private allergy clinic, you can refer whenever. I guess in terms of making it more worthwhile for the patient, trying to maximize some of those common measures initially, just to see if they actually, if they get better with washing bed sheets in hot water and using the nasal sprays and stuff, then they probably don't need to see an allergist and can just keep going with that. But if those measures aren't working and you're thinking about immunotherapy, that's probably the time to refer. But obviously, I mean, a lot of general practitioners are very busy and don't, to go through all of that information can take a long time. So if, we're happy to see them whenever, but yeah, generally, if they can do most of the conventional things first, that's a good step.
Thank you so much, Bella. On that, for anybody who isn't aware of the Community Asthma Programme, I found they're fantastic on education on allergic rhinitis as well. So if you have patients with asthma and allergic rhinitis, bring it up with the Community Asthma Programme. Just last quick question before we move on to the next speaker. Are biologics not as effective in allergic rhinitis in the same way they are as for asthma and atopic eczema? Or do you see an improvement on children in biologics?
Yeah, I don't think we know yet, to be honest. Uh, Yeah, I mean, I think I have several patients who are now on dupilumab for their severe eczema, and they also have allergic rhinitis. Some feel that it is better, and others feel that it makes no difference. I think part of it is that allergic rhinitis is so individual, like some people are just more tolerant of the symptoms than others. So it's really hard to standardize like a questionnaire to make sure that what is severe for one person is actually what we would think is severe. So I think it's variable. I don't, I don't use dupilumab for asthma. Like I tend to refer to the respiratory physicians if I think a patient's asthma is that bad. So I don't know whether that whether they have seen an improvement in allergic rhinitis using dupilumab therapy.
Yeah.
But yeah, I think the data it's still not clear. I think some patients have felt benefit, others haven't, and yeah, it's a bit to wait and see.
Great. Maybe some research for the future.
Yeah, it's an
Um,
interesting, I have a few patients who had allergic rhinitis and started immunotherapy, and then their eczema, just as eczema does, got worse and they needed to start dupilumab. And then it was like, oh, well, do we keep going with both? Is it going to negate the other? I think it's still really unclear.
yeah. Okay, thank you so much for your time, Bella.
No,
Our next speaker is Danny. However, looking at the list, his connection seems to have dropped out. Olivia, could you just confirm that? And if so, we'll move on to Debbie's talk in the interest of time, and we can come back. We can look back to Danny.
Yeah, sure, that sounds good. I'll wait for him to pop back in.
Great. Okie doke. So we're just going to skip Danny's talk because his link seems to have dropped out, and we'll move on to Debbie. What's new in the Australian Asthma Handbook 2025? And I will let Debbie explain that with all her expertise. We seem
Okay, can you see the slides now? Cool. Thank you. And thank you for the invitation to present. As was said, I'm a pharmacist. I'm the clinical lead at the National Asthma Council. And we have just recently, on the 16th of September, launched the new Australian Asthma Handbook, which is the guidelines for health professionals in Australia aimed at primary healthcare professionals. There's a QR code if you want to go to the link, but it's just Asthma Handbook .org.au. So we know that how prevalent asthma is, but we also know how poorly controlled asthma is in Australia. So we're just about to release the number of asthma-related deaths for 2024, and sadly, those deaths haven't changed over the last 10 years. And that's despite having amazing drugs, both inhalers as well as the biologics, that we've got an awful lot of potentially preventable hospital admissions, ED presentations, and a good majority of people live with poorly controlled asthma. So we're really hoping that these new guidelines and with our implementation plan both to consumers, to patients, as well as to health professionals will have a good impact. This is just looking at the goals of asthma therapy, and clearly we're trying to achieve long-term asthma control. But it's also reducing the risk of future exacerbations, because those exacerbations impact on your lung health, your lung function, but also impact on school and work and people's quality of life. There's that control is very, very important. I think one of the biggest challenges is helping people to understand that asthma is a chronic inflammatory condition. It's not consumers, patients talk about asthma attacks, and they tend to think that they don't have asthma in between those asthma attacks. And that's why compliance or adherence to preventers is typically very poor, because people will take, and I'll talk about over-reliance of salbutamol puffers just to relieve the symptoms of asthma, but they do nothing to address the underlying chronic inflammation that is associated with asthma airways. But it's also that changes over time. So people recognising their triggers. Clearly, we've just heard about allergic rhinitis or hay fever, and that can be one of the triggers that or comorbidities associated with asthma, which can set people off there. So we have changed, and I'm really going to highlight some of the changes and in the limited time I have changed the definition. Previously, it had good control, partially controlled, and poorly controlled. And now it's just recognised that you're either well controlled or good control or poor control. This is in adults and adolescents. We tend to lump them together. Clearly, the focus of tonight's presentations is the adolescents, so 12 and over. So we're aiming for good control, which is no daytime symptoms less than twice a week, using their relievers, salbutamol, less than 2 days a week, no limitations on their day-to-day activities, and no symptoms during the night or on waking. And then the opposite is true for poor control. Similarly, in children 6 to 11, it's those 4 parameters, but also it's identifying, because diagnosis is challenging in younger children, that symptoms only last a few minutes and that they have a good response to salbutamol. And the same goes with 1 to 5-year-olds. It's very difficult, if not inappropriate, to diagnose children less than 1 years of age with asthma. Usually the wheeze there is bronchiolitis, possibly associated with RSV infection. So this is a diagnosis for adults and adolescents. What has changed is the introduction of a pheno test, which isn't usually available in primary care, but is available in tertiary care, in hospitals, as well as respiratory labs. But also recognising the challenges of spirometry in general practice and the underutilisation of it, that if it's clinically urgent and suspected asthma, you can start treatment there as appropriate. And then across the same with children 6 to 11, different pheno cut point, greater than 25 parts per billion, and similarly very challenging in children 1 to 5, where they can't do spirometry. So some respiratory labs with specialised equipment and sort of very child-friendly labs can say they can use spirometry in 4-year-olds and over, but largely in children 1 to 5, the diagnosis is with a treatment trial based on their response, that rapid clinical response to salbutamol. And this is what has changed significantly. So for children 12 and over, the guidelines are now saying that no adult or adolescent should be using SABA alone. All kids 12 and over should be on at least budesonide formoterol, low-dose budesonide, taken as needed. And there's 4 different generics that are available, 4 different types of inhalers, which I'll go through, and then stepping up if they're not well controlled there. So the majority of 12-year-olds would start there and then step up if they're not well controlled to what's called maintenance and reliever therapy, which is where you're taking an inhaled corticosteroid and formoterol, taken as maintenance, so twice daily, and then using the same inhaler, the same molecules, same ICS formoterol as their reliever. And then if they're still not well controlled, stepping up to medium dose ICS formoterol as maintenance and reliever therapy. And then at level 4 is where they may, it's only for 18-year-olds over, add in a LAMA as triple therapy, or it can be added in tiotropium as Spiriva, Respimat. And then that's the point of referral to respiratory physicians to assess their criteria and knee eligibility for biologics, some of which are registered and approved in children.
Debbie, I'm so sorry to interrupt. I have a feeling that we are seeing you and I am clicking through the slides. Is that what people are seeing? Are they seeing Debbie's face or are they seeing Debbie clicking through the slides?
I'm seeing both Debbie and her slides.
So can you see the treatment levels, 4 treatment levels at the moment? Yeah.
If
Yes.
I click back, is that clicked back for everybody onto diagnosis of asthma, or is it still in Debbie's slides?
I think for me, I've selected Debbie's screen, so that works for me.
Everybody still sees the pyramid?
Yeah.
Fantastic. Okay, I was just checking. Sorry, something was happening on my computer. Apologies, Debbie, carry
That's all
on.
right. Thanks, Kirsty. It'd be very confusing if you weren't seeing the same slides.
Yeah.
And so that's the recommended pathway, those 4 steps, as you can see, starting with what's called anti-inflammatory reliever therapy, which is all children 12 years and over, for budesonide formoterol used as needed. You can see on the right-hand side of this pyramid shape that there still is an alternate pathway, and that's using maintenance ICS, low dose at the start, and a SABA, short-acting beta-2 agonist, salbutamol, as a reliever, and then stepping up to an ICS-LABA combination product and SABA as a reliever, either low dose or medium dose. But very much the recommended pathway is this left-hand side, where you're using the same, potentially using the same inhaler all the way through. So starting, just using it as needed, and then stepping up. And it is only with formoterol, so that's the long-acting beta-2 agonist, and it works just as quickly and just as well as salbutamol. And that is a fundamental change, and it really will be challenging for people, for parents looking after children with asthma that are so used to reaching for their salbutamol, their blue puffer, Ventolin, to name brand names. But the evidence is very, very strong, and I'll go through it. So air-only anti-inflammatory reliever therapy, I think we should be saying to patients those words for them to identify that that is their reliever therapy. So we do have a problem here in Australia and indeed worldwide, but I think our problem is compounded by the fact that we have salbutamol Ventolin inhalers available over the counter without a prescription. And therefore, many people are self-diagnosing or diagnosing their children and without a formal diagnosis by a GP. So as needed, short-acting beta-2 agonists alone is inadequate treatment for asthma in adolescents. And that's because it's been shown to increase the risk of severe asthma exacerbations compared with anti-inflammatory reliever therapy only. So this statement is one of the ones on the new website. I've just done a snip for it. So you can see that very prominent recommendations and alerts saying that treatment solely with as-needed SABA is not recommended for adolescents with asthma, even if symptoms are infrequent, okay? And just as a summary slide, we know it's a good question to ask patients or parents, how many SABA or Ventolin reliever canisters are you going through in a year? If it's 3 or more, that is shown it increases the risk of asthma-related exacerbations or flare-ups. And if it's 12 or more, meaning 1 a month, it's been shown to have a 32-fold increased risk of death. So sometimes we've got to scare people just to make them aware of the risks involved with just relying on salbutamol alone. So it's a good question to ask. And as I said, stepping up then to maintenance and reliever therapy, some people, if they first present with severe or frequent symptoms, might be started at level 2 or even level 3. And then if they're well controlled over reassessed after 2 to 3 months. That's what these arrows are indicating. They can be stepped down to a lower dose ICS or even stepped down to using budesonide formoterol as needed. And that's because we're trying to have people on the lowest possible dose of inhaled corticosteroids that's going to give them good control of their asthma. And then, as I said, stepping up and referral to respiratory physicians, specialists for assessment whether they are eligible for the biologics. You can also see here these horizontal arrows, which are new to the diagram in the new handbook. And what it's indicating, as you can see here, consider switching. So if you have a patient who still have symptoms and they're on or have been prescribed, and in younger children, it's only Flixitide, fluticasone propionate, and Asaba as reliever, we know adherence to maintenance therapy is poor. So rather than stepping up to a higher dose and still perhaps having poor adherence, switching across to the recommended pathway here, where you've just got that one inhaler that you carry with you, have in your school bag, have in the, you know, at home, where of budesonide formoterol, which you can either start with as needed or step up to maintenance and reliever therapy. In children 6 to 11 years, that budesonide formoterol currently is not registered in Australia for under 12, 11 and younger, and we're going to hear soon about the CARE trial, which was in those younger age groups. But at the moment, there still will be some children, 6 to 11 years old, where salbutamol is, as needed, is recommended. But again, for the majority of children, 6 to 11, they would be started on ICS maintenance at a low dose and using salbutamol as needed, and then stepping up if they have experiencing frequent symptoms or exacerbations, and that same sort of pathway stepping up. This is one of the new tables that's in the handbook, and again, this is just a snip from the website. And what it's highlighting, that almost like a decision table based on the pattern of exacerbations and symptoms and the severity of the exacerbations, whether or not a low-dose inhaled corticosteroid is indicated. So if they're just having mild exacerbations which resolve really quickly within a few minutes of having salbutamol, and that's happening less than every 3 months, that's okay to continue on salbutamol as needed. But if they're getting symptoms and exacerbations more frequent than once every 3 months, still mild and quickly resolving with salbutamol, that's a clinical decision. But once you could start getting up, having symptoms that are persisting and waking up at night, having an impact on daily activities, needing prednisone, those children are indicated to start on regular maintenance ICS, fluticasone propionate, Flixitide, plus Saba as needed. And then in the 1 to 5 age group, starting here, if symptoms and acute wheezing episodes are infrequent or mild, they would be on salbutamol, administered through a spacer and a mask in this age group, so a well-fitting mask appropriate for the age group and size of the face. And the same sort of thing if they're having a lot of symptoms, acute wheezing requiring oral prednisolone, starting at maintenance therapy and then stepping up. So similarly, there's this table looking at children 1 to 5 as a decision algorithm to help decide. So it's a much, much lower threshold for starting inhaled corticosteroids in both the 1 to 5 age group as well as the 6 to 11 age group. There are so many inhalers available now, and this is the newly revised wall chart, which is available. You can just order it off the National Asthma Council website, or you can print it off yourself if you want to. It comes as an A2, fairly large, and it will help. Many times parents might say, oh, it's the orange one. They might not remember the name. So it's a very useful wall chart. It does have these little symbols, on it, and this is identifying which products, which inhalers are available as anti-inflammatory reliever therapy with the A symbol, or maintenance and reliever therapy with the M symbol. The sort of A's and C's, A is for asthma, C is for COPD, because it's for both there. So really there are huge changes, and I really don't underestimate the challenges for us as healthcare professionals in the implementation of these guidelines, because we have had for so long people very reliant, overusing, over-relying on salbutamol alone, or they are prescribed a preventer, inhaled corticosteroid containing preventer, but are using it intermittently because they're asymptomatic. So really, really trying to use guideline-directed therapy to improve asthma control and reduce that burden of asthma. And, nobody should be dying from asthma in this day and age. To address the SABA over-reliance, and a lot of that will be education, both to healthcare professionals, as well as helping patients and their parents or carers understand the risks associated with just relying on salbutamol alone. And we are purposely using the word risky. It is risky. People may say, I've never had a severe exacerbation, but when you analyse the deaths from asthma, certainly not infrequently, they are people that would say they only have mild or intermittent asthma, and yet they have a catastrophic, whether it's from thunderstorm asthma, bushfires, dust storms, whatever, or just pollen triggers off their asthma, and especially in rural and remote areas where limited access. So big education, our role as health professionals, helping patients and parents understand that. And let's move to anti-inflammatory reliever therapy and maintenance and reliever therapy. Lots of benefits there, better control of asthma, reduced risk of exacerbations, especially severe exacerbations, reduced use of oral corticosteroids like prednisone or prednisolone, and cost also. Yes, salbutamol is available over the counter. It might cost $9, $10 or $12, depending what pharmacy you go to. But from 1st of January next year, the co-payment will be $25, so nobody will pay more than $25 for preventers like ICS formoterol. So the cost is getting less and less of an issue. And then finally, I'd just make a plug for the environment. PMDIs like salbutamol, Ventolin, really, we had 15 million in Australia in 2023. That's a lot of salbutamol. And a lot of them are thrown in the rubbish bins, in the landfill, and they were designed actually to slowly leak out the propellant, which has a high carbon footprint. We need to think about switching patients, if appropriate, to dry powder inhalers because they don't contain a propellant. And those dry powder inhalers like Turbuhaler, like the new Easyhaler, have significantly 97% less greenhouse gas emissions compared to PMDIs. But really, from the environmental point of view, good asthma control is what we're aiming for, and the environmental co-benefit of that less drives to ED, hospital admissions, etc., far outweighs the environmental impact of propellants used there. So it is a big challenge, but the education and awareness is hopefully the message is getting out. And I very much hope that you will have a good look at the website. I've only given a brief overview of it, but they're the most substantial changes. Yeah, and I'll leave it there, I guess. Yeah, thank you.
Thank you so much, Debbie. Brief but comprehensive. I think that covered everything we were hoping for. In the interest in time, because we have a lot to cover still, and the fact that Catherine's presentation carries on so nicely from yours, I might let people ask questions in the chat, and we'll move on to Catherine's presentation. So if you have questions, if you could pop them into the chat box, and then we'll answer them after Catherine's and get through Danny's as well. So introducing Catherine Chen.
Great. Thanks, Kirsty. It just flows really nicely from your talk, Debbie. As Debbie has highlighted, the main changes is around not using salbutamol at all for the adolescents and adults, and the emphasis on the anti-inflammatory reliever therapy or the maintenance anti-reliever therapy. The question then comes, what about those children less than 12? Is that treatment pathway as effective too? And this is the very first paper, to my understanding, the CARE study, that look at this regimen. So this is a randomized control trial comparing the anti-inflammatory reliever, budesonide formoterol, which most of us know it as Symbicort, versus salbutamol in this randomized control trial. Next slide, please, Kirsty. All right. So in this population, it is children aged 5 to 15. The important things to note is the cohort in this study are those children that we would consider as mild. So children who use salbutamol on an occasional basis. To be included in this study, they can't be on any preventer for the last 6 months, and they can't have had a hospital admission for the previous 12 months. So really the common garden, GP office, clinic patients that you see. On the intervention arm, the children had budesonide 50 micrograms and formoterol 3 micrograms as a metered dose inhaler through the spacer. So this is a lower dose than we are familiar with our adolescents, which most of us use the 100 microgram or the 200 microgram budesonide. The comparison arm is standard therapy, which is salbutamol 2 puff as required. The outcome that the study measure is asthma attacks, which they define as any exacerbation that you need to see a GP or go to emergency or hospitals. And they divide that by the number of participants over the time that they observe the patients over. The study timeline was across a year. Next slide, please, Kirsty. And if you click again, that will highlight the main findings. So the main findings and the key outcome was the group that was given the anti-inflammatory reliever have about half the amount of attacks compared to the standard arm. So it was about a 50% reduction in asthma attacks. The 95% confidence interval could be as small as a reduction in 35%, but could be as big as 86%. So quite a significant reduction in asthma attacks. There was not much difference in terms of time to the first attack or the number of them. Next slide, please, Kirsty. All right, and if you click again. So the question is, does this approach also improve the overall asthma control? So interestingly, in this study, they measure the asthma control questionnaires as we're quite used to when we see patients. And there were no differences between the visits in terms of the patient or the family reporting of the asthma symptoms. And then if you click on the next box, the FeNO, which is the measure of the nitric oxide expire, which is a measure of the inflammation of the airway, there wasn't much difference. The study authors wonder whether the approach that we're using in terms of using the anti-inflammatory inhaler when you have symptoms may just be effective in reducing the asthma attacks, but may not play a big role in the overall asthma control, or Is it because in these young children, often they do need to rely on their parents to give them the inhalers, therefore perhaps different from the adult who can reach for it as they need to and therefore are more proactive? And the other theory is perhaps the dose is not big enough. As you know, as Debbie has presented to the adolescents and adult, we will be using somewhere close to 100 and 200 micrograms of budesonide as needed rather than 50 micrograms. So some unanswered questions regarding the longer term asthma control. Next slide, next click, please. All right, and this is a very important question. So when we implement this kind of approach, I'm often asked by families, what about the impact on height or growth? As there's no concerns in the community around the use of corticosteroids. In the study, when they compare the height in the beginning of the study to the end of the study in both groups, there were no difference. So this approach did not impact on the growth of the child. As I often say to families, if you have poorly controlled asthma, that would also affect your growth. So it is definitely a balance. Next slide, please, Kirsty. All right, so what does this mean for clinical practice? I think at this moment, it's still a little bit of watch this space. As we know, the budesonide formoterol is still not on PBS for the age group less than 12. It is only on PBS if you have not responded to standard therapy of inhaled corticosteroid and you need it as a maintenance therapy. So that is available, but it's not available at this point as an anti-inflammatory reliever for the mild group. The other issue is that we don't actually have the formulation of the budesonide 50 micrograms as the study has had. So it's not quite ready for implementation, but I think watch this space. You know, my feeling is perhaps even for the younger children, we might be moving towards a similar approach to our adolescents and adults. And at this point, there's a current ongoing study of the preschool age children with this similar approach. So, we look forward to sharing some more data with you, hopefully in the near future. That's it from me, Kirsty.
Thanks so much, Catherine. It's a really nice summary of how things are changing there. We'll swap back down to Danny's slides now, and perhaps while I'm getting there, Debbie, maybe you could answer a question in the chat box for us. Apparently some information from the drug rep field saying that they are going to start a eco-friendly MDI propellant. That's something you've heard of?
Yep. So new, what called low carbon propellants will be introduced over the next few years. It's being mandated in Europe, so they've had the first one, which is a triple ICS LABA with these low carbon propellants, but it will be a good 2-3 years before we get them here in Australia.
Thank you so much. Now introducing Danny and his wealth of experience with thunderstorm asthma.
Thank you, Kirsty, and thanks everyone. It's been really great listening to you guys. Sorry, my internet dropped out twice, and hopefully, oh no, got to go back. Hopefully, it won't drop out anymore. I'm one of the senior medical advisors in the Department of Health in Victoria and been involved in thunderstorm asthma since 2016. And I'm assuming that if you're here at this community of practice, you know a fair bit about asthma. You probably know a ton about thunderstorm asthma. You've seen all the graphs. You probably know all the messages. And what I'd be really keen to do tonight, if it's okay, is to use this COP and to use your experience and expertise in being practitioners at the coalface and to help me understand. So help me understand how the program is working. What, have any problems, any concerns, any improvements, any ideas. So in the spirit of a community of practice, I'm here to present some information that might be new or that hopefully clarify some bits that are a bit tricky or not clear. But hopefully this is really honestly a two-way conversation. Drop stuff in the chat or, ping me later or whatever if you've got an idea of what the state government can do to improve things, perhaps. Because, I'm in there. I can't guarantee anything, but I can certainly jiggle with the policies or the comms or the how we prepare, or I can advocate. So really do what you can. Everything I will very much appreciate. And I thought I would start being a bit of a tease and saying we've made a new video and my slides won't move. There we go. There's not enough time to play the video. It's only 3 minutes, but it might be good to show your patients if they've got time. And essentially it talks about a thunderstorm asthma event that happened in November last year in Albury-Wodonga. And there was 121 people presented to the ED. Majority were mild to moderate asthma. There was no intensive care unit admissions. Sorry, go back. Terrific. And 70 were aged between, 70 of the 121 were aged between 20 and 50. And it sort of speaks to the first point that I'd really like to make. And that we have this sort of event, and we had a similar one in Cup Day in 2023 that I'll explain a little bit more later. And we also had the world's largest event in 2016, which was such a different beast. If you could, next slide, please. And you've probably seen these slides before. And essentially, we had huge numbers of calls to 000 and AV. 650 odd code 1 calls to ambulance. And they're meant to respond in 15 minutes. That's the time. But this was an enormous amount. And almost 3,500 excess asthma presentations to EDs in Greater Melbourne and Geelong. Almost 500 asthma admissions. In the public system, 30 people in intensive care and overall 10 deaths. And in the 2 days that followed, we estimated 10,000 extra asthma presentations to GPs in Melbourne. And the confidence intervals were pretty wide, so it could have been 25,000. And it's a really challenging sort of type of event to have a system run normally and then suddenly surge to such high amounts. And this is one of the reasons why we have the epidemic thunderstorm asthma forecast to prepare the system. And I am hopeful that people in primary care are using it. And I would really love to hear if people in primary care are using it. Is it useful? Is it not useful? How could we improve it? Or you've never heard of it. If you could drop something like that in the chat, that would be very much welcome, because it's useful for me to know if we need to increase comms out to primary care to say this is a thing, or if it doesn't hit the mark, then maybe we could change it somehow. Next slides, please. What I wanted to focus on is the more severe end of thunderstorm asthma. And of the people who went to ICU, and this was not only the public but the private system, so the numbers are a little bit different, 33 of the 35 people admitted were adults, and the ages range from 21 to 69 years of age. And only a third were using inhaled corticosteroids. So a bit different to the guidelines now, but still, only a third. Of those who died, and this is from the coroner's, they were aged between 18 and 57. So no children, 70% were male. Only 2 had previous admissions for asthma. Only 4 had a preventer. And only 1 had an asthma action plan. So that was in 2016. So, getting to 10 years ago. But interestingly, everyone who had who went to ICU or who died were people who were diagnosed with asthma, doctor diagnosed with asthma. These weren't the people who had hay fever and might have their first episode of asthma, that we know turned up in the ED, and there were lots of those people. And of course, we know that, not enough people were on preventers, and a tiny amount of people had asthma action plans. Now, I'm going to change the tone a little bit, because really what I'd like to do is to read you a summary of some of the cases that went to the coroner's court. And those pictures, there's 6 of those people died. These pictures were, sorry, next slide, please. Those pictures were taken from the newspapers. They weren't from us, so they're public. Omar, the young lad, top row, second from the left. Omar was born in Australia. At the time of his death, he was 18 years old and just completed Year 12 studies. He lived at a Greenvale address with his mother and 3 sisters. When Omar was 5 years old, he was diagnosed with asthma and placed on an asthma management plan and was prescribed Ventolin and Seretide. Omar led an active lifestyle as a child and young adult and was involved in a number of sporting activities. He developed seasonal hay fever in his later teens, which was treated by oral antihistamines and nasal sprays. On Monday 21st at 6 p.m, Omar was observed in the kitchen struggling to breathe after having been outside. He had taken his Ventolin and Seretide inhalers, however, continued to deteriorate and was driven by his mother to a Greenvale Medical Centre. Moments after arrival at the medical centre, he collapsed on the floor. Omar's mother called for an ambulance, but was on hold for approximately 16 minutes. Omar was relocated to a treatment room where he received medical treatment and cardiopulmonary resuscitation. Paramedics arrived, but Omar had passed away. That was Omar. I actually happened to speak to his dad just a week ago, and he was telling me how he spoke to him not that much longer than this happened, and they were talking about the clothes he was getting for his graduation. That was really coming up. Another really scary case was Ling Ling, who was at home with her husband. Both went outside to check if their new pergola was leaking in the heavy rain. Ling Ling returned inside. The windows of her home remained open. About half an hour later, Ling Ling's husband returned inside and sat down, watched the telly. At this time, Ling Ling tapped him on the shoulder and went outside again. Moments later, she returned back inside and reported having significant breathing difficulties and requested to be taken to the medical clinic, which was only 100 metres away. On the way there, she lost consciousness. Only 3 minutes had passed from when she tapped her husband on the shoulder to arriving at the clinic. Her husband was assisted by passers-by to get Ling Ling out of the car, and an ambulance was called between 6:13 and 6:32. CPR was commenced and a doctor at the clinic assisted. At 6:45, the ambulance arrived, at which time she'd been in cardiac arrest for 17 minutes. She was transported to Northern Hospital and arrived and didn't survive. Another part of the coroner was due to unprecedented demand. Ambulance Victoria were only able to attend approximately 57% of Code 1 cases within the target timeframe of 15 minutes. So it's there's lots to be learnt from these deaths. These are really tragic deaths, and probably for me, one of the things that pops out, particularly for this audience, is 2 out of 10 people died in a general practice. And that's not because of the care that they received at the time. It's more to say that if we get a really, really big event, someone could turn up to your clinic really, really sick. If the ambulance is meeting high demands, then they might take longer than anyone would wish. And I hope that GPs and primary care are preparing for this sort of eventuality, but I don't know. And I'd love to hear if anyone's in general practice land or anyone knows, is this on your radar? Is this something if clearly you do when you practice and when you're confident, or is this really not a thing that's front of mind? So please drop something in the chat if you can, or because I'd love to know, because it changes what I do. And really, I'm going to change the tone back again. I'm sure everyone knows that thunderstorm asthma is, related to high pollen. But what you might not know, or maybe you do, is the 2016 season was below average. So if you look at the two maps of Victoria, 2014-15 and 2016, the brown stuff is, dirt because it was very dry and there wasn't much grass growing. In 2016, we had the big rains in September and there was grass. But if you look at the curve underneath, 2016 is the red curve. The one above it is the average cumulative pollen for the season, and the highest is the green dotted one. So if you hear a commentator saying, oh, we're not going to have a high pollen season, it really doesn't matter in terms of preparing for thunderstorm asthma, because 2016 had a below average cumulative pollen season. So essentially it means every year you got to be prepared, because it can happen. It only takes one high pollen day to cause the risk. And this is what happened. You've probably seen this. 2016, the storms formed a beautiful linear convergence line that pushed everything across the city and exposed, 5 million people who happened to be walking home, at the end of the day. Next slide, please. And on Melbourne Cup Day, I don't have a moving image for that because we weren't expecting it. You'll see the little cluster of storms in the, what's that? Melbourne, also on the other side, sorry, it's weird not running the slides. Next slide, please. On that day, this is the pollen forecast, and it was extreme. And it was Melbourne pollen because they used to, before 2016, they only had one pollen counter, and that was at Melbourne Uni, and it was the Melbourne pollen count. Now we funded them to have, a whole bunch of pollen counters, and they do the Victorian pollen forecast. They also work interstate. But that's a question that was raised, I think, earlier by one of the earlier presenters. Anyway, I digress. So the pollen was extreme, but the thunderstorm asthma forecast was moderate, and some lows up in the Mallee and Wimmera. And that's because of the storms. Next slide after this. Sorry, these slides go a bit wonky, I think. If you do the next one, click the next one. No, you go. Okay. No, maybe go back to the blue ones.
Getting
Number
there.
11.
Just hold on 2 seconds. My computer is slightly upset at me. There we go.
Oh, beautiful. Okay. You won't see the numbers, but this is what happened on Melbourne Cup. So Northern Hospital had 50 cases of asthma. In the north, Dandy had 50, Monash had 40, and as did Casey, and there was 30 asthma cases in Frankston. Werribee had 20, and Shepparton had 30 cases. Ballarat had just over 10. So, on that day, on the 7th, there were 240 odd asthma cases presented to EDs. That's not insignificant. And the following day, there was 200 attended EDs. So these are large localised spikes of asthma cases. They're different to the 2016 by an order of magnitude, but they're not trivial. And ambulance did well, 000 did well, and EDs did well. And we like to think that having all the work that's been going on with everyone preparing and able to sort of surge, that's actually helped us manage these sorts of spikes. How we do in a 2016 event remains to be seen. It will be challenging, but we're working as best as we can to make sure that if such a hazard sort of eventuates, then we're as prepared as we could be. Next slide, please. And of course, the question is, what's the difference between the patterns? And it's because of the storms. There are different types of storm structures, and some will actually just, expose a whole lot of people. And when that happens, we'll get the big epidemic thunderstorm asthma. So to be able to talk sensibly about these two sort of phenomena, they have the same cause essentially, but they have such a different outcome. So the thing is we're saving the epidemic thunderstorm asthma really for a big, big event. And we're starting to use the language of a high asthma presentation day for these smaller spikes that are important. People need to prepare for them, but they don't, thankfully, they haven't caused any deaths. The system is managed, ambulance is managed, 000 has managed, EDs have managed, and I guess we're hoping that we don't get a 2016 event and we just have all these smaller ones. But we do have climate change happening, and we know that will bring more severe storms and possibly more aeroallergens. So, we will have to wait and see. And I
Danny,
guess, yeah.
Sorry, just in the interest of time, I'm just going to ask, feel free if you need to log off at 8 o'clock. Thank you for coming. And we usually do run over a few minutes when we have particularly interesting speakers. If we could move through to what can we do practically in the community to help prepare our patients for these events, not just ourselves, but prepare our patients for these events.
If you want me to well, there's a whole lot of, essentially, good asthma care. And asthma care talks about triggers, and one of the triggers is thunderstorm asthma. And what can you do with that? You can avoid exposure to a trigger. And how do you avoid exposure to thunderstorm asthma? Well, simply, if you stay out of storms during grass pollen season, you go indoors, close your windows, and turn off your air con that brings outside air in, so the evaporative ones. Hopefully you won't get exposed, and hopefully you manage. But how do you know that a storm's coming? Well, you may want to use the thunderstorm asthma forecast. And where do you find that? Vic Emergency has it. It's on one of my slides. Or the Melbourne Pollen app. And the tricky thing about the forecast is that the forecast is a 3-day forecast. And if you're looking for the forecast for today, the forecast, don't look at 9:30 in the morning, because that hasn't been updated. We update today's forecast at 12:30. Because that's when we get the most up-to-date weather information, and that's used to calculate the risk. And the events really happen in the evening and afternoons. So if you want to know what the best risk is for today, you look up Vic Emergency after 12:30. If you want to know what's tomorrow or the day after, that's updated at 3 o'clock. So before you go home, look at the forecast. It'll be updated for tomorrow. and then you can plan your day. I guess, the other, apart from to answer that question, having good asthma care is really, the secret sauce, and hopefully the new guidelines will help this. And using thunderstorm asthma, it's a little bit more interesting than plain asthma, and so lots of people talk about the tail wagging the dog. So you can potentially get more interest in patients by talking about thunderstorm asthma. I don't know. And there was one more thing I was going to say. There's a ton of, thank you. There's a ton of, information on the Better Health channel, and we've translated a whole lot of things into 27 different community languages. The other thing is, we would love the community to know about asthma first aid. And the more people that know asthma first aid, the more they can help their family members or pass, other people who are in distress. And if it becomes part of our basic cultural knowledge in, Victoria, that is prone to these sorts of things, then all the better. It's like preparing for a bushfire or a heat wave. This is stuff we all should know. In terms of clinics, I don't know if people have systems for looking at the forecast, knowing that maybe there's a high-risk forecast for today and what that might mean in terms of people turning up. Or if we ever do have an event, you'll be really busy in the following 2 days. Telling people and preparing, we do a seasonal preparedness piece every year, and whether primary care can do something similar. And, initially people were sending SMSs to, their patients who have asthma and say, oh, look, we're moving into springtime, come and, let's review you, let's update your asthma action plan, let's talk about how you manage a whole lot of things, including thunderstorm asthma, or check out these resources. And remembering, getting your asthmatics under good control and knowing what to do when there's an exacerbation is terrific, but also capturing those people with hay fever. So, if we can manage those minor cases and they don't crowd into ED and they don't call the ambulance, it means that those services are left for people who are really, really, really unwell. I might stop there because, yeah.
You did it. You managed it all, Danny. Fantastic. Thank you so much. I know we're a bit rushed, but there's always a lot to get through in the springtime. And I think you bring up some really important questions. I don't know if anybody wants to speak to Danny's question about preparedness in GP. One of our GPs in the chat said that they do situ sims around emergencies, but they haven't done a specific thunderstorm asthma one, which is a great thing to do. I think some of the issue is having something like an asthma champion in hospital is a fantastic idea. Having one for the practice is also a great idea, and probably your practice nurse is a good person to do that. When I worked in the UK, practices work a bit more collaboratively, and you tend to have illness leads. So there would be an asthma lead, a diabetes lead, who would keep up to date and do learning and journal clubs on these things. We're slightly more independent practitioners, and depending on the way your practice works, people see different things. But I think the practice nurse is always a good person to be an asthma lead. Perhaps check the Melbourne pollen forecasts or the Vic Emergency app every morning. In terms of being prepared for once in a decade or once in a lifetime emergencies, I think that's more difficult in GP, and I think we need to be reasonable of what we can keep up to date with, but also what is safe to be expected of GPs. I worked that event and I had 12 asthmatics, I know all having attack at one time, and to be able to manage one of them had they become very acute with extensive hospital training and pre-hospital care training that I have, would have been nigh on impossible without resources and any other trained staff. So it's very difficult in the community. But I certainly think having emergency runs-throughs and warnings and systems and preparedness, such as phoning another member of staff to be on call should that happen again, would be fantastic. I cannot see any more questions in the chat, so please feel free to put them on. You can email us questions afterwards. And thank you for sharing those stories as well, Danny. That was really moving, and I think really impactful. So I'm just going to go down to my summary because we're a little bit out of whack. Just to let you know, anybody who wants to follow up on new changes to asthma, the paediatric protocols, Health Pathways Melbourne keeps up to date. You can see it there. I'll also give a plug for the RCH. They also have very good guidelines on their website. Log into Health Pathways. On the left-hand tab, you'll see asthma. There is acute asthma in children. You might want to refresh yourself on managing that. And then the different age groups that we manage. You also can log CPD for Health Pathways reading now, which is an important thing to note. And you can find that under the health system, and again on the left-hand tab, CPD hours for Health Pathways use. If you don't have access to Health Pathways, you can use that QR code, or you just go in and sign in and register online. I'm sure everybody here will have a Health Pathways register and login by now. And a second plug for the Community Asthma Programme. If you're not familiar, the Community Asthma Programme is a DHS funded, fully free service for any child up to 18. They are a nurse-led service who can spend up to an hour each session with your patients in the home, over the phone, or in practice. They can also visit schools and daycares to provide education. I find them invaluable to my asthma practice.